Hello again. It is my pleasure to introduce you to Dr. Mimi Owusu. Dr. Owusu was born in the U.S. to Ghanaian immigrant parents. In toddlerhood, she moved from the U.S. with her family and lived as a third culture kid for over a decade while moving every 2 to 4 years between different European cities. Migrating back to the U.S. as an adolescent in an environment that was not particularly welcoming of her differences was a deeply challenging experience that impacted her mental health and led her to initial interest in psychiatry, with a special interest in work with children and adolescents. Dr. Owusu has been blessed with an outstanding education that serves her patients well. As an undergraduate, she attended Harvard University, where she studied psychology and enjoyed creative extracurricular activities. She carries a master's degree in the science and medicine of athletic performance from the University of Oxford in the United Kingdom, where she focused on athletic sports such as gymnastics, figure skating, and dance. She maintains an interest in working with athletes around the intersections of athletic performance and mental health. Dr. Owusu completed her medical school training at Yale University School of Medicine, where her thesis focused on weight and mental health in pediatric populations. She completed her adult psychiatry residency training at Massachusetts General Hospital, MGH, and McLean Hospitals, both affiliated teaching hospitals of Harvard University. She served as an administrative chief resident and received the prestigious Laughlin Award for her strong residency performance. She then stayed at MGH and McLean Hospitals to complete her child and adolescent psychiatry fellowship. She carries double board certifications in adult and child and adolescent psychiatry. Dr. Owusu spent many years working for Boston University and Boston Medical Center as an assistant professor, child and adolescent outpatient psychiatrist, and serving as the program director for the adult psychiatry residency. She is proud to have received several teaching awards throughout her career from medical students and residents alike. Throughout her career, Dr. Owusu has supported the training of medical students and psychiatry residents in the West African region through didactic, teaching, and significant administrative support. She has spoken regionally, nationally, and internationally regarding her education and global work, in addition to publishing journal articles and book chapters on global mental health, resilience, and mind-body medicine. All of these experiences have molded Dr. Owusu into an astute diagnostician who is easy to connect with, thoughtful in her treatment approaches, and deliberate in understanding the impacts of people's identities and life experiences on their mental health. Dr. Owusu currently applies these skills as a staff psychiatrist for students at MIT. In addition to work with individual student patients, she runs a group therapy for graduate students identifying as LGBTQ+, that allows for dialogue around intersectional experiences in higher education, and will soon be transitioning into a role focused on connecting with the student body outside the clinical office. Dr. Owusu.
I'm going to set a timer for myself so I don't talk your ears off. All right, thank you guys so much for having me. As you heard, my name is Dr. Mimi Owusu. I'd like to extend my appreciation to the church in general, and then in particular to Dr. Karen Singleton for the invitation to speak today. My talk is entitled, All Peppers Do Not Ripen Simultaneously. Or, when all peppers do not ripen simultaneously, what's a farmer to do? Looking around, I'm imagining that for most of you, you're like, what are you talking about? Sounds kind of opaque. It's an unexpected title. And I'll explain where it comes from. It's an English translation of an Akan proverb. Akan is the name of a meta-ethnic group of people and a set of languages, primarily located in today's country of Ghana. Ghana emerged by that name when it gained its rightful liberation from colonial rule of Great Britain in 1957. The proverb, when written in the Akan language of Cree, is Mokonyina impetu emre, or all peppers do not ripen simultaneously. That proverb also birthed the Adinkra symbol Mako, which is depicted on the screen. It's the almost target symbol with the spikes around the edge. Adinkra are symbols that represent an aphorism or a concept. In this case, the Mako symbol depicts growing peppers, and Mako, the word itself in Cree, which is in Akan language, means pepper. In this symbol, all of the peppers growing on this plant are equally plump, they're equally juicy, but we recognize that naturally, that's probably not typically the case of a pepper plant. Mako, the Adinkra symbol, comments on equality versus inequality of opportunity and development. And as with all things African proverb, it's highly metaphoric, so I'd like to break it down a couple of times. First, as I personally see it generally, and then secondly, as I see it applied to the mental health of Black women and girls. So, generally, I believe that the Mako symbol and proverb reminds us of four things. The first one is that peppers have differences. So meaning that naturally, each pepper that grows on a plant has disparate endowments. Some peppers are double the size of others, some have a different color, some are mild, and some are really hot. Number two, that these differences are not inherently bad, though we may be told that they are. So if a farmer is expecting a really hot pepper yield, and the pepper is actually super mild, that farmer is probably going to be fairly irked by it. But there may be a different farmer or a cook for whom that mild pepper is exactly what they're seeking. So in the end, all of the peppers will have ripened. They just may have done so in their own unique ways. Number three, that extrinsic environmental factors, not inherent to the pepper itself, can impact its growth. So for example, some peppers, maybe they're planted in a pH-balanced environment, they receive natural fertilization, a lot of water, and that leads to strong growth. Whereas another pepper may be placed in acidic soil, it's shielded from sunlight from overgrowth, and it may yield much smaller fruit. And number four, the Mako symbol reminds us that it is in the collective power of the overall pepper plant and its guardian, the farmer, to acknowledge these differences and promote redistribution and helping in support of each of the different pepper fruits to ensure that all the peppers ultimately ripen to their potential. So you heard in the bio that I'm a Black child, adolescent, and adult psychiatrist. I'm also the child of Ghanaian immigrants, and I'm specifically Akan. So in those identities, among many others, I really value the wisdom of my heritage and experience in supplementing my academic and clinical training on mental health. So what I learned academically and clinically was not necessarily developed in an environment that was meant for people like me. So I have to pull from other experiences to apply it appropriately, in my opinion. So I take from things such as the Mako symbol and its associated proverb, and I think, how can I synergize the message of this proverb with my understanding of mental health? So I'd like to take the next few minutes to apply that proverb and these four principles to an understanding of mental health in the Black community, specifically for Black women and girls, and offer some practical ways to think about it. And I hope that it'll help you understand manifestations of distress in our community, how to recognize the risk of progression from distress to mental health crisis, and strategies and challenges around seeking care. So that first principle, Peppers have differences. I am confident that's not lost on anybody in this room that people also have differences, right? We come from different places, we have different backgrounds, our minds and our bodies have subtle differences that make us beautifully unique. And just like other systems in our body, each person's individual brain functions to generally accomplish the same tasks. So we're trying to process information, we're trying to keep ourselves alive in the face of constant threats of danger. Our brain is working to be the CEO that regulates other parts of our body. And our brain allows us to take pleasure in things like creativity and interpersonal interactions. But just like other body systems, take the musculoskeletal system, for example, there are also little differences. So maybe there are some people in this room who can engage in long-distance endurance activity very easily. I'm not one of you. My body is more attuned to short sprint power moves. And there are other subtle ways in which our brains are also uniquely tuned to work differently from each other. For example, some folks may tend towards really deeply valuing social time spent with other people. We would call that something like extroversion. And there are others who might find that super draining, and it's beyond limited doses of social connection, and we'd really refer to them as introverts. Or the brains of some people tend towards considering all of the potential possibilities and outcomes in a situation. They're constantly contingency managing, maybe even worrying about the future. And there are other people who may be a little bit less detail-oriented, a little bit less future-focused, and more present moment-focused, sometimes to the extent that they're forgetting to prepare for the future. Principle 2. I think that these brain differences are what make us all interesting. It's what makes your conversation with your friend, your neighbor, or your colleague intriguing, because their thoughts and their motivations and their actions are actually quite different from yours. So sure, sometimes some of us may get annoyed with that person who's chronically worrying, but that quality in them is probably also what makes that person exactly who you want to be next to if suddenly it starts raining and you weren't prepared for it, because they have like 3 umbrellas in the bottom of their bag and they're going to share it with you. Or we may feel irked by the person who's always flying by the seat of their pants. They're grabbing things at the last minute, they're walking out the door, running late for school or for the bus, submitting an assignment several hours late. But in a different context, that's exactly who you want to be with when you're kind of bored one day and you're looking for something spontaneous to do. They're going to drag you somewhere and not tell you where you're going to be. It's going to be the best day ever. You're going to remember that day forever. So our brains ultimately each have relative strengths and weaknesses, and we can learn to harness those strengths in an ideal environment. So I would say another example of this is in my work with youth. There may be a child who struggles in sort of a standard academic environment, and maybe that relates to having differences in learning. So reading is very difficult for them because of dyslexia. But that same child, if you place them in a really creative environment, a drama classroom, they're excelling beyond everybody else. They just need to find their environment. But as a brain doctor, I also know that not infrequently the different ways in which our brains work go beyond just quirks, and sometimes there's suffering or distress that we experience within ourselves or in our relationships with others or in our progress towards our life goals. And we can think of suffering or distress as the persistent presence of negative emotional states. So something like sadness that always sticks around. It's obviously okay and necessary to be sad sometimes. It's a basic emotional response to a sad event. But if someone can't emerge from that sadness for weeks at a time, it becomes distress. A clinician might term that depression, but I actually think it's way less important what labels placed on it. Our labels are actually fairly problematic. And the most important thing is that the person themselves are struggling, or that somehow their life has veered off course as a consequence. Or if you take worry, that's another basic emotion that is necessary to plan for things or to react when the world is scary. But when one cannot exit that state, when you're permanently in fight or flight, it can enter a realm of distress. and a clinician might call that anxiety. So sometimes brain differences lead to persistent negative emotional states or maladaptive behaviors. So we've talked about a couple. We mentioned sadness, we mentioned worry. There are other things like isolating from other people, not spending a lot of time with the people that you love and care about, or engaging in use of substances that ultimately leads to greater detriment, or changing the way that we're eating, either under or overfueling ourselves, or engaging in or considering self-injury. Principle number 3. The environment in which we find ourselves has a disproportionate impact on the risk of us developing distress. So just like every bone in our body has a breaking point if you put enough stress, strain, or force on it, every brain, no matter its supposed resilience, which is a useful concept but can sometimes be weaponized, every brain has a limit at which some of these signs of distress will emerge. So society expects a very narrow definition of what is acceptable behavior, what's acceptable functioning, acceptable thinking, or if your mind tends to work in a way that's a bit different from that, you're much more likely to experience distress. Or if you're in an environment with a large amount of systemic oppression, which we are all in, you're chronically battling that, your risk of mental distress increases. So if each of you take a second to think about your own intersectional identities, you can likely think of several ways in which you exist in a high-risk community. I'd like to also point out that we often think of systemic oppression in larger societal context, but the impact of that oppression can also occur within our individual households, and it can carry just as much weight. So if there's a family member who gets ostracized for reasons of identity or difference within a single household, they're also at higher risk. And of course, trauma also has this impact. So I would classify trauma as the bad things that are done to us by others, or horrifying experiences that we've had, or ways in which we've been disregarded or neglected, left without basic needs being met. And that can significantly contribute to progression to emotional distress. So we heard before that data is important, and I agree. But I have to admit that I really hesitate to provide data because it's always so depressing to look at American health statistics by race. Super depressing. And the truth is that you guys already know the answers to the data. So rather than me giving you specific numbers, I figured I would just ask you the questions and you can tell me which direction the data trends, because like I said, y'all already know, right? So, what is the relative prevalence of mental health conditions in the Black community compared to that of other racial groups? Is it higher or is it lower? Correct. In what direction is the suicide rate of Black youth and young adults trending? Up or down? It's increasing, yeah. It's actually increasing in youth everywhere, of all races. But how does the rate of change in suicide in Black youth and young adults compare to that of other racial and ethnic groups? Higher or lower? It's higher. So between like 2018 and 2021, the rate for Black youth increased 36%. How do the rates of Black utilization of mental health services compare to that of other racial and ethnic groups? Higher or lower? Lower. So I'll take a second to just comment that both for this number 4 and then for number 1, it's fraught. It's fraught for essentially reasons of medical racism, right? So there have been, and continue to be, different diagnoses, different times in history where the medical system tends to label people certain ways in a very racialized way, right? And because of that, because of lots of basically racist trauma within medicine, it is hard for groups to commit to seeking care. So it's not actually surprising that utilization rates would be lower. How does the population of Black mental health providers compare to the national Black population? Is there an overrepresentation of Black health providers or an underrepresentation? Like under, yeah. So Karen and I are unicorns, basically. The US Black population is about 14–15%, and at most, if you take all of the many different types of mental health providers, at most you're gonna find 5% within a particular population, so maybe 5% of all social workers are Black. So my core principle number 4. In the spirit of that proverb, it is the community responsibility to support the growth of all of the peppers. So you don't just have to sit idly by and watch yourself or others in distress. If you notice yourself struggling, or if you notice a friend, family member, child, colleague struggling, how can you take up the mantle as a community farmer to support them? I believe that one of the things of greatest impact that we can do in our community is to decrease stigma. And how do we do that? By increasing the number of people who openly discuss the emotional distress or mental health challenges as just a fact of life. That's why it's really important to me personally. Like in my bio, you heard my whole desire to enter medicine, my desire to enter psychiatry derives from my personal experience. This is not an experience that is relegated to somebody off in a corner who should be kept away from society. We've all been touched by this. Choosing to reduce stigma can be as vulnerable as choosing to share about one's own experience, or as simple as reflecting on the challenge as something that can impact any of our community members. It's not a value judgment. It's an acknowledgement of human experience. If you proactively open the door to this conversation for your children, in particular, you are less likely to find yourself being the last to know when they're struggling, at times when they could really use the additional support. It becomes just what is acceptable to acknowledge and talk about in a household. We can reduce stigma by recognizing that we all have our time of mental health struggle, personally or intimately in one of the people that we love and care about the most. So we should really watch the language that we use when we're observing someone struggling. The deeper I've gotten into mental health, the more I'm like, what does the word crazy mean? It's no longer in my vocabulary. We should watch the language that our children are learning to use. We should watch the ways in which we choose to humanize or dehumanize others in their struggle. A community farmer will get to know themselves and the people around you so that you can tell if something changes about them. That can look like shifts in how they relate to you or others, or changes in the way they're choosing to spend their time. Changes in their behavioral patterns, becoming more irritable, or changes in their function, how they're getting to work, whether they're accomplishing the work, whether a child can get to school, whether the child's successful at school the way they have been in the past. A community farmer will be cognizant of vulnerability and check in with their people accordingly. So if there's a loss that occurs or is anticipated, a transition like a separation or a divorce or a move, if there's a traumatic event or an anniversary, the community farmer is there recognizing, man, my person is vulnerable. I gotta go find them. The community farmer chooses to proactively check in and engage, not to preach, but to serve as someone who's listening without judgment. And how do you do that? By choosing a low-intensity environment and a low-intensity moment. So ideally not when things are at their hottest, unless you're really, really, really concerned about like their physical well-being in that moment. And just asking an open-ended question like, how have you been feeling lately? Or contextualizing it non-judgmentally. I've noticed you've been a bit more distant in the last few weeks, and it makes me wonder, how have you been feeling lately? And finally, with the hope that that openness to conversation leads to acknowledgement of the distress. That person may not know what the next step is, and as someone who's committed to being a community farmer, you may be able to support them in seeking support. That support can come in a few different ways. We mentioned that the medical system and the mental health system can be complicated for many different groups of people, but certainly for Black people. So it doesn't necessarily have to come through there, but I would say if someone has been trying other things and those things have not been working for them, I would certainly encourage people to consider it coming from there. So I've included a few different resources. So hopefully you guys can actually read that from afar. Can everyone kind of see it? Okay. There's essentially a mental health crisis 911, which is 988. So the 988 lifeline is something that is available to folks. There are other crisis resources that are more physically manifest, things like the emergency room or crisis evaluation. Those things can be really scary for people. So if one finds themselves in a position of needing to support someone in getting care of that nature, I think as a community farmer, it would probably be really helpful to go with that person or to figure out who can be the person who's there for them. And then for identifying that unicorn mental health provider who shares aspects of your identity, I've included a few different resources. So for example, therapyforblackgirls.com offers a database of Black mental health providers who are interested in caring for Black women and girls. I think the challenge of these websites is because there are so few of us, I think it can be hard to go on the website and find that someone actually has availability, but I would encourage you to do so. And the other thing I would encourage is, if that's not an option, to seek out deliberate questions of other providers who may not share your identity. So telling them that your identity is important to you, asking them if they've had patients like you before, asking them if they feel comfortable engaging a conversation around race, identity, ethnicity, sexual orientation, et cetera. And giving it a few sessions. And if it's not cutting it, I think it's okay to find someone else, right? Because it's super vulnerable and it's important to feel connected. So I will end there. Thank you guys. I hope you'll remember that all peppers don't ripen simultaneously. And feel free to email me. And we may have time for any questions if folks have any. I want to make sure I'm understanding your question also, that other people heard it. I think you asked me to expand on the concept of the community farmer, like my thinking on it and what does that mean. I think that mental health struggles, emotional struggles, are inherently isolating. Like for so many of the conditions that we struggle with, we just want to struggle alone. And I think to be a community farmer is to decide, like, I'm gonna help grow the plant being the community around me. I'm gonna help grow the plants. And so even though you wanna stay isolated, I'm not gonna let you. I'm gonna be proactive and I'm gonna engage. And that actually I recognize that as my duty, as also a member of this pepper plant, essentially. So hopefully everyone recognizes that as part of their role. And I think one of the ways in which the peppers don't ripen simultaneously is that there may be times that I can offer my community farmer support to you, and times that I need it from you, and those may not be simultaneous. Yeah, I can try to go back to it. I'm assuming you want it in English. So it's the title of the talk. All peppers do not ripen simultaneously. Yeah. Hi. Yeah. Yeah. It's um, such a good question. I feel like there are entire, it's a heartbreaking question. There are entire courses in schools of public health around how deeply messed up our healthcare system is structured, right? So you're bringing up a really good point, which is one of the other reasons that there can be underutilization is just a lack of access. So one component of access is, are there providers? But another component is, let's say you find the perfect provider for you. Like, I'm not saying I am, but like, let's imagine it was me. I sit at an institution where I can only see a certain type of student, right? And so there are all these silos around healthcare. How would I think about it? I would think about a couple different things. So one is we have essentially a multi-tiered system. If someone really has the most limited levels of access, so that might be someone who has no insurance or is super underinsured, so that often happens with people who have an immigration status that does not allow them to have a full insurance package. Often you can try to get your care at one of the sort of major safety net hospital settings. So I mentioned working at Boston Medical Center, or I think in the bio, it mentioned working at Boston Medical Center for a period of time. That's primarily who I was seeing in that context. And that was deeply meaningful work to me because I felt like I was offering the opportunity for what I wanted to be quite good care to people who might not otherwise be able to access it in a sort of private setting. One of the other things to think about, so you mentioned like your specific insurance, for example. So if you do have access to insurance and you go to one of these databases or other databases that exist, you can often filter by what that insurance is. And so if I'm helping someone to try to identify a provider, I always say start by filtering by your insurance. Yeah. And then there are a number of providers, because a lot of mental health practitioners also work in private practice, who will offer reduced fee or some sort of sliding scale. So in the sort of wider context of the community in which we exist, like the entire United States, if you are someone who has privilege, who has access, and you are seeing a provider like this, you have the ability to kind of supplement someone else's opportunity to get care with that provider. So that's the way I conceptualize it, but it's deeply flawed. What advice would I give to the Peppers? Yeah, I think, let me go back to I think a lot of these principles would apply. So I think each of us is a pepper, right? I think I've had times in my life where I thought, oh God, I'm like the most shriveled pepper ever. Like I'm not, pretty the way other people are pretty. I'm not this, I'm not that, I'm not, But I think the point is that every pepper actually has equal potential. Your potential just may need to fit with like the environment that you're in. So I would say that that's one thing. I would highlight the extrinsic environmental factors as well, which is, I think, particularly important in the context in which we're sitting right now. When your pepper plant has been assaulted over and over and over again, there are consequences to that. And so I think just acknowledging what are aspects that are, this is intrinsically me and how my mind works versus what am I responding to in my environment. Yeah, I think I would stick with those two for right now. Yeah. Yeah, that's great. And to concretize it, like 12-step AA type models is one really excellent example of that. And those models apply to substance use, but they can apply to several other things as well. So they can apply to people who maybe themselves are not struggling with substance use, but they have family members who are, or it can apply to people with eating disorders, et cetera. Yeah, I like that. Yeah. Nice. Mhm. Yeah, I think some aspects of what I shared today around how to gently open up conversations are expanded upon in formal mental health first aid type of sessions. And so if you're looking to get more facile in having those types of conversations, get more facile in how would I support someone in seeking supports, a session like that would be great. I mean, we've talked for, 20 minutes today? So a session like that would be several hours long, and so I think you would leave feeling much more, not sure why that's happening, much more facile in how to engage in these conversations, especially if you already know that I'm interacting with this all the time and it's something that I desire. I would like to feel more comfortable. Oh, absolutely. Yeah, yeah, yeah. It is designed for lay people, so it's not medical school. It's not a psychology training. It's designed for anyone in the community to be able to engage in. Yeah. Okay. Any other questions? Yeah. Mm. Yeah. Um, I think the first thing that I start, so I'm a psychiatrist. Some people may have familiarity with what that is, and some people may not. Um, we mentioned before that I went to medical school. One of the distinctions between psychiatrists and other mental health professionals, a lot of us can do a lot of similar things, but psychiatrists are one of the unique fields in our ability to prescribe medications. And I would say psychiatric nurse practitioners are another, and depending on where in the country you are, sometimes physician's assistants as well. So I think one of the important things to me is to not be a pill pusher. I think medications can be helpful, but I would say in 99% of my appointments, I say, these are options for you. If I felt like you absolutely had to take this, I would tell you that, but it's just an option. And I want you to know the potential benefits, the potential risks of this option that's available to you. The other thing that I think is important, especially in communities of color, is to reinforce that the benefits are something that you are worthy of. So I think that sometimes people, partially due to stigma, just sort of sit in the suffering, and if a medication can be helpful, I think that someone is worthy of alleviation of suffering. So I try to reinforce that for my patients. And it can be really hard. It can be really hard if someone has made a decision not to take medication that could be helpful to them, or if it's taking a while to, like as a provider, to bear witness to that suffering while it's happening. Because I've seen so many patients potentially get better off of some of these medications. So hopefully that answers your question. Why? Yeah. I mean, I think it's, there are probably 35 reasons. I think one of the reasons that, like in particular, I mentioned that 2018 to 2021 value, and I think we continue to see it increase since 2021. I think some of that relates to COVID and all of the many sort of consequences related. Yeah, exactly. So much of it relates to structural racism and the consequences of that. I think I increasingly find myself feeling quite old school. I think that to be a kid in 2025, like being a 10-year-old in 2025 and being a 10-year-old in the 80s is just so different. Like social media, the pressures that are associated with it, I think just the onslaught of what people are getting is quite different. And there's kind of no off button. Like you used to go home and you weren't still engaged in all the pressures of your middle school life. And that doesn't turn off anymore. So I think there's a lot of data around like social media and the consequences of it. Yeah. Okay, thanks guys.